Good afternoon. My name is Dr. Lisa Homa. I'm coming to you today from Elizabethtown College, located in Elizabethtown, Pennsylvania. I'd first like to start the presentation by extending our deepest appreciation to King's College for hosting this amazing event and for the exceptional work of Professor Bolton in organizing all the details. We are excited for future collaborations and look forward to learning and sharing with you in the future. The technology I'll be using in the classroom today is an app called Socrative, and so you'll need to log in and create a Socrative account. The classroom is Homa, H-O-M-A, no space, 192. And through that, you'll be able to participate even though I'm not speaking to you live synchronously like we had initially intended. You'll still be able to poll and take the quizzes accompanying this lecture. Before we get started, I'd like you to start with the first quiz of the day, and we'll just keep moving. The intended outcomes of this lecture are to provide an overview of the biggest challenges facing nurses in America, to illuminate challenges nurses face in managing the opioid crisis in America, to provide an overview of healthcare disparities in America, to describe the challenges leading to moral distress in new-to-practice nurses. So what are the biggest challenges facing nurses in America? The first challenge we're going to discuss is the opioid epidemic. And I am certain that you are quite familiar with the epidemic. Opioid epidemic continues to rise in our numbers, and it's a considerable problem here in the United States. So you can see on the slide that there is a top 10 celebrity list of the most famous celebrities who overdosed from opioid. And I'm just going to do a quick run through of a couple of them that you may be familiar with. I tried to pick celebrities that you may be familiar with in the UK as well. So here's the top 10. Heath Ledger overdosed on a blend of prescription meds. Kurt Cobain, lead singer of Nirvana, overdosed on a combination of benzodiazepines and heroin. Anna Nicole Smith, controversial actress and a Playboy bunny, she overdosed on benzos and opioids. Jimi Hendrix, very famous guitar player and incredible musician, overdosed on a blend of barbiturates. Elvis Presley overdosed on opiates. Marilyn Monroe overdosed on high levels of barbiturates. Michael Jackson overdosed on a blend of benzodiazepines and propofol, which is a sedative, hypnotic, and IV anesthetic. Whitney Houston overdosed on opioids and a benzo combination. Prince overdosed on fentanyl. And Chris Farley overdosed on a blend of cocaine and morphine known as a speedball. So before we move on, I want to give a nice overview, and I have a 4-minute video for you to watch first.
When I think about the opioid crisis, I think what we're really talking about are deaths due to opioid overdose. And so an overdose can occur really anytime anyone uses an opioid. And when I say opioid, that's really an umbrella term that includes things like painkillers, prescription painkillers, so Vicodin, Percocet, oxycodone, all the way to heroin and actually to the opium poppy, which is where originally these substances were derived from. So that's sort of the big term. And what we've seen in Massachusetts and across the country has been this dramatic rise in unintentional death from overdose on these drugs or medications. And while, again, this can happen anytime someone uses an opioid, most often when we see these deaths, it's due to untreated opioid addiction. So often we're really talking about right now is a crisis of opioid addiction. And one of the reasons that's so devastating and all of these deaths are so devastating is that opioid addiction is a completely treatable illness. And so really no one should be dying from an overdose because we have things we can do in the setting of an overdose to save someone's life and to keep people safe while they're actually in the throes of addiction. And we have treatment that we know reduces the death toll and helps people get into long-term remission to lead meaningful lives that really shouldn't be foreshortened by this disease.
Every day I encounter people in recovery who inspire me and who really give me hope around this. You know, I think a lot of what we hear about in the media is the, people who aren't doing well, people who are, tragically dying. Most of the people that I have the privilege to work with are really making great strides in their lives. It's an inspiring thing to watch, and I feel privileged to be a part of that. And it really gives me great hope for the future.
The opioid crisis began about 15 years ago when we saw an increase in the prescription of opioid analgesics or narcotic analgesics, or sometimes referred to as pain relievers. Because we saw such an explosion of prescriptions, what we found was that more people than ever before were exposed to opioids. In past generations, not very many people were exposed to opioids, but with this surge in prescribing, with a genuine intention of relieving pain, those who have a vulnerability to becoming dependent on opioids or developing an addiction problem on opioids were now exposed.
With the prescription opioid pain medication, it seemed like there was an abundance of these drugs everywhere. I had a lot of friends that also had injuries that were being prescribed medication. It just seemed like it was easier for my generation as an underage person to get access to illegal prescription narcotics on the streets than to get somebody to buy you alcohol because of the accessibility of these drugs.
The problem that we have currently is that practitioners are literally all over the map. Some people will not prescribe anything for any condition, and some people will give 30, 60, 90 pills of oxycodone or hydrocodone. And so I think what's happening is that we're creating this severe problem of expectations for patients because they don't know what they're going to get from which doctor. We need to do a better job with that.
I pretty much started using drugs. Actually, I started drinking alcohol before the age of 14. And then eventually from there I progressed into snorting cocaine, and it was probably around the age of maybe 20 that I started snorting heroin.
The opioid crisis is twofold actually. It's prescription medication and also powdered heroin, and now the introduction of fentanyl and various forms of that. So it's taken on two folds where we have to attack it from both ends.
The opioid crisis, it's affecting everybody. I mean, it's in every community. It doesn't discriminate against anybody. It doesn't matter poverty, doesn't matter race, doesn't matter where you come from. Every family is affected by it.
Hopefully the video provided a nice overview in case you were unfamiliar with the opioid epidemic. And then I'm going to talk just a little bit about background that they didn't cover, which I think is important because it really adds to the story to put all the pieces together. And then I'm going to talk about the three waves and where we are today in opioid overdose. And then we're going to talk about nursing care and some solutions to that as well. So if I'm looking at the graph that is on the slide, before wave one, typically opioids were only prescribed for the really sick or a patient who had severe case of pain. And so typical patients that we would utilize this for in the United States, a patient with a surgical wound or who just had surgery, or a patient with cancer who typically is associated with a lot of pain, or terminally ill patients as we prepare them for end-of-life care. What changed is that new painkillers, and one in particular really has changed the landscape of opioid epidemic, is OxyContin. OxyContin was introduced by pharmaceuticals in the 90s, and they were aggressively marketed with misleading claims that the drugs were less addictive than other forms of opioids. And the most recent update to that saga is that in 2020, in October of 2020, so there were 3 pharmaceuticals who produced OxyContin. The most famous one recently pled guilty in October 2020 for fraud and kickback conspiracies, and they admit that they significantly contributed to the overprescribing and then also to enhancing or creating more issues with the opioid epidemic. So as a result of OxyContin coming on the market, prescribers thought it was a better drug to use, less addictive, They started prescribing OxyContin and opioids like crazy. There was a sharp increase, as you can see, so now we're beginning to talk about wave 1. Sharp increase in the availability of narcotics. Many people were prescribed OxyContin. It was prescribed initially for legitimate use, like for chronic knee or back pain, but eventually they became dependent on the drug, and then it led to abuse. Wave number 2. Over the next decade, prescribing practices exploded, and individuals who lack access to legitimate sources, like a provider, turned to heroin because it was cheaper and a more accessible replacement. By the second wave, the incidence of heroin overdose was 19 times higher in those who already tried other opioids and were more likely to convert to heroin use with a previous history of prescription narcotic use. The overdose deaths at this time involving heroin tripled. So what changed that caused wave 3? So now in 2014, fentanyl came on the scene. Now 60% of all opioid overdoses were caused or involved fentanyl. So why is fentanyl so deadly? Fentanyl is 50 times stronger, more potent than heroin, 100 times more potent than morphine, and it is more easily produced than all other drugs, and it's relatively cheap. The majority of fentanyl is produced in China and widely distributed throughout the world. The most current statistics, 70% of all opioid overdoses now involve fentanyl. There are 3 countries that have been the hardest hit by the epidemic. The 3 top consumers of opioids are America, so the United States is number 1, Canada follows right behind, and number 3 is Germany. So let's talk about other factors that also impact the susceptibility of addiction. And the one burning question that we all want to know is, why do some people become addicted while others do not? There have been many studies done, family studies in particular, that have observed identical twins, fraternal twins, adoptees, and siblings, and they have suggested that as much as half of a person's risk of becoming addicted to nicotine, alcohol, or other drugs depends very specifically on their genetic makeup. Have you ever heard of the phrase nature versus nurture? It's a pretty old saying, and actually what we're starting to find with all these new discoveries and research is that it is no longer nature versus nurture. It in fact should be nature plus nurture. And let me give you an example of this. In a community we have found that provides healthy after-school activities has been shown to reduce vulnerability to drug addiction. And the data show that access to exercise can discourage drug-seeking behavior, an effect that is more pronounced in males than in females. Let's go one step further. I'm going to do a little brush up on your genetics and your epigenetics. Genetics is simply defined as the study of genes. Genes are functional units of DNA that make up the human genome. They provide information that directs a body's basic cellular activities. On the flip side of that is epigenetics, and maybe some of you are familiar with it or maybe you're not. It's pretty new, but we know that the study of epigenetics has been around since the 1960s. Epigenetics is the study of functional and sometimes inherited changes in the regulation of gene activity and expression, and they are not dependent on gene sequence. So just think about that for a second. So let's break down the word epi in genetics. So we know epi by itself means above or in addition to. So that means in addition to the normal 50% of tendency that is coming from our genetics with addiction, we know that it's alluding to environmental influences. So let's talk about that further. We know that environmental exposures or choices people make can actually mark or remodel the structure of DNA at the cell level or even at the level of the whole organism. So although each cell type in the human body effectively contains the same genetic information, epigenetic regulatory systems enable the development of different cell types, for example, skin, liver, or nerve cells, in response to the environment. These epigenetic marks can affect health and even the expression of traits passed to children. And let me give you an example of what we're seeing in the research. When a person uses cocaine, for example, it can mark the DNA increasing the production of proteins common in addiction. Increased levels of these altered proteins correspond with drug-seeking behaviors in animals. Isn't that fascinating? There is an international group of over 100 scientists used a comprehensive database to collect information on smoking and alcohol use behaviors. They measured behaviors such as age when smoking was initiated, age when smoking cessation occurred, number of cigarettes per day, and drinks per week. The scientists then cross-checked those findings with life events. Overall, what they found is that there were over 400 locations in the genome and at least 566 variants within those locations that influence smoking or alcohol use, bringing science closer to identifying a cluster of genes that could play part in addiction. Research from epigenetics is really important, and what seems to be most important is not only leading us to mutations in the genes, but leading us to new therapies targeting the treatment of addiction. There is a whole specific scientific area that is working on this, and it's called pharmacogenomics. So this slide shows what our old saying used to be of nature versus nurture. This is actually more accurate, and this is what we're finding from research, is that it's a combination of our genes, so a 50% influence of the genetic traits or mutations that we can identify on a gene. It's a combination of individual choices on what we choose to do and a combination of the environment or environmental influences. Between the three of these now comprise epigenomics and how we express disease. So now, how do we address the opioid epidemic in America? There are 3 areas that we're working to have an impact in the opioid epidemic, and the first is prevention, the second is treatment modalities, and the third is focusing on recovery. An addict cannot be cured, be healed without having or addressing the 3 components of treatment. I'm just going to provide a highlight of a few of the areas that we're working in on the prevention front to try to make a difference in opioid epidemic. The first is, somewhere in the literature, they mention universal design. It usually refers to standardizing an environment, but they're using it quite a bit in talking about making changes as far as standardization, education, prevention, treatment, and recovery with the epidemic. So as far as prevention, nurses can facilitate reducing barriers to effective pain management. They're on the front line of care, right? Nurses are in the perfect position to be able to influence and impact and improve patient care and outcomes. One area that we have addressed that is significant in the area of prevention is that our clinicians could benefit from continuing education so that we all prescribe things in the same way. Because what's happening is when a patient goes to a doctor, they don't know what's going to happen. There's such inconsistency in our prescribing practices among clinicians that area specifically needs to be addressed. The second thing we're noticing is that there's quite a bit of stigma. I'm not sure how familiar or how much research is happening in the UK with stigma. Specifically, we call it here, one particular area is called health-related stigma. And we know that when patients or individuals feel stigmatized, they don't show up at our provider, so they won't come to follow-up appointments. We know that they don't seek care and that they will circumvent or create workarounds so that they don't have to go back to those providers. This is a targeted population that we know that if we can help them to utilize the system rather than go around the system, that we could have an impact in this area. We've also identified significant barriers within our insurance system and reimbursement. So we know that patients who have chronic pain management issues, there are lots of alternative options for them besides having opioid pain medications. The issue is that they are not covered by insurance and patients can't afford to cash pay for those services. So we know we have work to do with that. As far as treatment, we know that we can provide a reagent or an antidote for an opioid overdose, which is Narcan or naloxone. So we are supplying police cars, lots of different agencies within the community with what we're calling a Narcan or naloxone toolkits or overdose kits. So one is having the medication where we need it right on the scene to have an immediate impact. And then another area we've identified that we haven't done very well is also storage and disposal of narcotics and opioids. And what I mean by that is, let's say that you are part of the care team caring for someone going through end of life. They're prescribed opioids, typically morphine, for the dying experience because dying is painful as the body shuts down. And then the family is left with all of these opioids and other drugs once the person or their loved one passes away. So to combat this, we realize that we have all these drugs sitting around and patients and families, or the families, don't know what to do with them. So we've created a lot of education, and we also offer follow-up appointments now after a patient passes away, where we can discuss to make sure that storage and disposal of the prescription opioids have been cared for appropriately and that no one else gets hurt. Another area we've discovered that we really need to focus are in the recovery efforts. So in helping a person to overcome opioid overdose, it's not just a quick fix. It needs to have a lot of different disciplines involved, and clients need counseling, support, and combined behavioral therapy, in addition to helping to ease their physical signs and symptoms of withdrawal as well in the initial phase. As far as recovery efforts, we also know that many drug rehabilitation centers are not covered by insurance. Many halfway houses, they're filled up, so there's no occupancy or there's no room available for patients in the recovery phase, especially if they're homeless. And we also know that we have to work to make our rehab centers more available and affordable for patients who need to go through withdrawal and recover from addiction. So let's talk specifically about the nurses' role in the opioid epidemic. So registered nurses are specifically positioned in the best way possible to have an impact. They are on the front line. They can address the epidemic by firsthand educating patients to understand the risks and benefits of pain treatment options. Also, by recognizing those at risk for a substance use disorder, so we can look at their past history and determine their risk. And then I have a video, it's a 3-minute video that's going to just cover this really unique option. So there was a hospital in Paterson, New Jersey, who came up with a really innovative solution and a new program, which is really having a great impact. Their local solution became a national solution, and it's now been spearheaded by the Emergency Nurses Association. And I thought, instead of just complaining about an issue, I thought it would be a great thing for you to see some innovative solutions that are having an impact.
The Emergency Nurses Association is an indispensable resource to the global emergency nursing community, representing more than 43,000 members worldwide, and the opioid epidemic is one of their top priorities. An estimated 7,000 people are treated in emergency departments daily for opioid-related complications.
As an emergency department nurse, we see patients every day who are ill because of using different opioids, and we wanted to make a change.
And at St. Joseph's Health, they are making changes. Maria Christensen, a member of the Emergency Nurses Association, spells it out for us.
ALTO is an acronym for Alternatives to Opioids.
It's an innovative solution to reducing opioid addiction and overdoses developed here at the Paterson, New Jersey location. When a patient comes in, providers first consider non-opioid options, over-the-counter pain medications, holistic methods, nerve-blocking injections. When opioids are necessary, ALTO calls for the lowest possible dose for the shortest amount of time. The results are dramatic.
We had an 85% reduction in the prescriptions that were written for opioids.
Doctors and nurses here, with the help of the ENA, began to build on that success.
And then in furthering the research, we partnered with the Emergency Nurses Association to further bring this to light. Now that we've seen that there is a potential for reduction in prescription use, we want to make sure that we get that information out on a national level.
They did that too. The ALTO program became part of the SUPPORT Act, sweeping federal legislation to help fight opioid misuse, which was backed by the ENA and recently signed into law.
It's huge.
Judy Padula is the Vice President of Patient Care Services at St. Joseph's Health.
And it's contagious because other departments started to jump on board. So for example, the OBGYN department started an ALTO program themselves.
But they still train daily to combat the opioid epidemic on the street, the ground level, where overdoses are so deadly and emergency nurses are the first resource.
Open up your Narcan boxes.
This brand is Narcan, a nasal version among many other forms of naloxone.
See the mist that we need to create.
The opioid overdose reversal drug, Narcan, saves lives when seconds matter.
Usually intranasally, it works fairly quickly, and they'll start to come around, hopefully, and wake up.
So in a place where they get real results, it's no surprise when you get real talk.
A lot of patients are angry when they wake up because we just destroyed their high. So you go through a gamut of emotions with the patient because of the way the illness is.
It's that focus on practical and clinical approaches that leads to ideas and collaborations.
In addition, we did partner with some of the rehab facilities in the area that have drug counseling. And so when a patient comes in and if they overdose on medication, we can call in a counselor who will meet with the patient right in the emergency room and then set them up with treatment if they're interested.
The Emergency Nurses Association is an advocate for change, and they're doing this through their community of nurses worldwide. An impact that is being made from a local level through to a national level, where emergency nurses are serving as a vital voice in the opioid challenge.
It's a strong advocate, but it's a loud advocate as well. So there are a lot of people involved. We can touch a lot of people throughout the country. And our partnerships with ACEP, AAENP, those types of organizations really support that, and that we really work well together.
So ENA, we're going to continue partnering with other organizations to continue battling.
And continue distributing the ENA toolkit so facilities can tailor the ALTO program and all ENA initiatives to fit their patients' needs.
Is it outpatient therapy that they need? Is it providers that they need to be able to connect in patients with on the outpatient side for treatment? What are those resources that they need? Because everybody's a little bit different.
It's often the differences that bring these hardworking professionals together.
Have you ever met an ED nurse?
Those who have are glad they did.
That's a great way to support patient safety, which is a part of ENA's mission as well.
The Emergency Nurses Association is fiercely driven to advance patient safety and excellence in emergency nursing, especially when it comes to the opioid epidemic. In Paterson, New Jersey, I'm Craig Boswell.
So I didn't have a chance to mention that I don't like students falling asleep in lecture, and so I usually create little crazy slides or GIFs to help keep you awake. And so here's one of my crazy cats, hoping that you're not sleeping through this presentation. And then I also wanted to quiz you on some of the things that we learned in the earlier segment. So if you think you're so smart, please try this. So quiz number 2, and here's the Socrative number. And I did launch all the quizzes, so you should be able to take them when it's convenient for you. So normally I would have a question time here if there was anything you didn't understand or I could explain further. But I will leave my email, so please feel free to reach out with any questions in the future. I'd be happy to answer them. Now we're on to Health Challenge number 2, Health Disparities. So there is a little pre-test on this slide, again, using Socrative. It's launched, so you can take it when you're ready to test a little bit of your knowledge about health equity and health disparities. There's been so much said in the United States this year about disparities and unequal treatment and racism. And so I think we may be a little bit saturated here in America on some of these topics. So I'm just going to mention it briefly, nothing as in-depth as the opioid epidemic. But here's for us where things have really started. So I'm just going to share a little bit of our historical background that you may not know. So this book is maybe familiar to some of our students here, but it may not be familiar to you. If you recognize this book was commissioned by our Congress to write, and it was published in 2002 by the Institute of Medicine. The commission reviewed over 100 studies at the time, looking at issues of race and ethnicity and health outcomes. So the 2002 commission found that racial and ethnic minorities receive lower quality health care than non-minorities. They also found that even when income insurance status, and medical conditions were similar, that we still had health disparities. And I'm going to share a few statistics with you of what has been found in the time period between 2002 and 2010 when things were really getting started, and then I'll share a little more on that. So the findings were African Americans were 4 times as likely to develop end-stage renal disease, and even more shocking, 70% as likely to be referred for renal transplantation when compared with non-Hispanic whites. That is so powerful. Second thing they found is that Latinos with fractures, and they were long bone fractures, were 2 times less likely to receive pain medication in the emergency department than non-Hispanic whites. Third finding that was really groundbreaking is that Asian Americans had a lower rate of colorectal and breast cancer screening than non-whites. And so a good way of showing it, this is kind of an easier way of showing the disparities among groups, is using something like infant mortality. So if we look at infant mortality at the time, so this is rate per 1,000 live births, we've been generating this report since the 1980s. Let me back up for 1 second before I explain this. You could look back at the previous slide, what I just talked about, the findings with Latinos, and you could dispute that and say, well, what if Latinos with long bone fractures, what if they refuse pain medications? Maybe that contributed to changes in the data. You could go on and on. You could look at all these variables that could have impacted that previous study that identified disparities. However, in 2006, there was a study done by Hannon et al. That evaluated clinical appropriateness and patient preference, and they specifically looked at what I just gave you the findings in the previous slide. And they did find that there were very subtle changes in the data, slightly overall, but they found that disparities are driven from the operation of healthcare systems, the legal and regulatory climate, and issues of frank discrimination. So now back to this slide. And so what you can tell is that non-Hispanic blacks had 10 times the infant mortality than non-whites. So you can see that we have significant issues. These are our most vulnerable populations here in the United States with respect to health disparities and showing this considerable gaps that we have. So when we're looking at the next slide, really what drives health outcomes? And some of the things that I find that are really incredible about this slide is that most of us who are in clinical care or provide clinical care to our patients and clients, we think that clinical care is what really drives outcomes. But when you look at this slide, what's so powerful about it is above clinical care and below clinical care. So clinical care is identified as only contributing 20% of health outcomes. Above it are health behaviors that contribute 30% of health outcomes, and below it are social and economic factors that contribute 40% of health outcomes. Now really put that into perspective. You take the 30 and the 40, that equals 70%. So 70% of our health outcomes here in America are driven by our health behaviors and socioeconomic factors. That is huge. That is absolutely huge. And that really can explain why we're seeing the numbers that we're seeing with health disparities. It's starting to make sense. So now we have to talk about social determinants of health. So just a reminder to make sure you're familiar, social determinants of health are conditions in the environment in which people are born, live, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. Wow, that is a mouthful. So when we look across here, you may be thinking, okay, so who cares? So instead of just seeing a mishmash of a bunch of different social determinants of health, I think it's more powerful to talk about what is the strongest social determinant of health. And so we're going to do exactly that. So you can take a quiz and see if you can guess. It's question number 4, but what do you think it is? It is the wealth gap. So wealth gap by far is the strongest social determinant of health. And what that means specifically is home ownership. It's ownership. It's what do you own? So in the United States, we know that Black families have a deficit 10 times that of whites, which is pretty significant. So when we talk about socioeconomic status, we know that persons with better education and jobs or more wealth live longer They have fewer health problems than those with a lower socioeconomic status. And again, that's pointing to that 70% when we talk about social determinants of health. And then education predicts infant mortality in both Black and white groups equally. The higher level of education, the lower mortality, so the lower infant mortality rate, and also, boy, this is a mouthful, the lower levels of low birth weight infants. So what does cause health inequities after all? So from the U.S. Census population in 2010, we know that differences within quality of care causes social inequities, differences in access to curative and preventative healthcare services, and differences in life opportunities, exposures, and stresses that result in differences in underlying health status. In the United States, in 2043, whites will become the minority. So think about this. The evidence suggests that bias, prejudice, and stereotyping on the part of healthcare providers may contribute to the differences in care, often despite their best intentions. So first, I'd like you to be able to watch this video. This is a 3-minute video from IHI Institute, which is the Institute on Healthcare Improvement, and they've done some amazing work in helping with health disparities. It's a short 3-minute video which will provide a little overview of some creative solutions that have been attempted to help improve health disparities.
Our goal is to reduce the gap while improving care for all. So when you look at reducing the gap, there's one way to do it is to decrease your performance for one cohort while either staying the same or increasing for another. And so we talk about it in improving rates for everyone while reducing the gap. For example, we have our goal of reducing disparities gap in mammography, and we had one clinic that came up with this bright pink ticket idea. So they call it their pink ticket for the mammogram. And the workflow is the radiology tech looks at the schedules the day before, cues the scheduling or the reception staff as to who needs a mammogram. When that patient comes in, the receptionist gives them a bright pink ticket and says, "So you're due for mammogram today, why don't you get it? Here's your pink ticket, we'll make sure you get it today." Well, that pink ticket also serves it as a decision aid for the nurses and for the physicians and clinicians to recommend the mammogram. So then when the visit's done, the nurse escorts the patient to the mammography area and introduces them to the mammography tech, who then takes the patient to get the mammography. And this was a test of change that was developed by the receptionists and the nurses and the radiology techs. Well, they got their gap to less than 1%. And so one clinic trying one simple test of change that we've now spread to other clinics. When I trained and when I started, we were trained and we set up our clinic systems to have preventive visits, and then we would have chronic care visits, and then we would have acute care visits. And so it was very possible that a patient might come in for a diabetes visit and we didn't realize they were in need of a mammogram. And so then we'd be chasing them afterwards to try and get them back in. But patients don't think of themselves as, this is my preventive visit, this is my diabetes visit, this is my visit for my back pain. And so when we redid our workflows, we said every patient, every visit, and what's the recommended care. So that if a patient comes in for back pain, we're recommending any preventive services they need. We're dealing with the diabetes care that they might need. And we're using the full care team members, where most of this used to fall on the physician or the nurse practitioner. It's now the nurse, it's the scheduler, it's everybody helping to identify the needs for that patient and supporting that patient. In our state and the country, we're becoming more diverse. We need to certainly improve the care for our patients, but it's also about having it be a welcoming organization and having our patients feeling confident and comfortable in our care. And so from that standpoint, yes, because it helps us grow our organization. In the case of mammography, when we're doing same-day mammograms, I think we've done 6,000 same-day mammograms over the course of a year. Well, that helps the bottom line, and it's recommended care. It's not overuse. And so by doing this, it's the right thing to do, and it helps us with triple aim, both from the standpoint of quality patient experience, affordability, because we're catching disease early, and then also even from the bottom line on where recommended care isn't being done, then we've got the opportunity to provide that as well.
And to build on what was mentioned in the video is the triple aim of health equity. So one of the things that we're doing to eliminate or reduce the gap is what's called a racial equity toolkit. I'm not sure if you're familiar with that, or you're likely way ahead of us. And if you are, I would love to know about that and hear about all the things that you're doing in the UK. But here we are, I think, pretty behind. And we have begun using racial equality toolkits. Cultural competence has become a very important concept that we're integrating into all of our curriculum for all of our students in higher education. We also want to make sure that all education that we provide, again, uses universal design, and that's making all places where people live, learn, work, and play at any age with any disability or any underlying health issue, where people could utilize accessible accommodations, services, and support. The use of the racial equity tool can help to develop strategies and actions that reduce racial inequities and improve success for all groups. And don't forget to take your quiz on health equity. Any questions, please feel free to email me. And then again, here's one of my crazy cat tricks to keep you awake to make sure you're still there. Now we're on to moral distress in new to practice nurses. This is challenge number 3. There is a pre-test on testing your knowledge about what you know and understand moral distress to be, and this is a 4-minute video just to provide an overview to get you to understand what moral distress is and some of the issues that our nurses are facing in America.
Moral distress is different than other problems nurses face in their work environment because it affects the nurse emotionally, psychologically, and physically. The nurse has to deal with things that are not within their control. And so we classically define moral distress as knowing the right thing to do and not being able to do it because of some kind of external constraint. A lot of times nurses are feeling these symptoms or these emotions and they don't know what it is, they can't put a name to it. Or the organization doesn't recognize it and know how to help that nurse or group of nurses deal with those scenarios, those situations that happen. There's been research and there has been work done in trying to identify moral distress, but there's still lots of nurses who don't know what that research says or what's been written and learned about it. And I think that's still surprising to me that it's still so unknown in many parts of our country. Some of the signs and symptoms that might alert the nurse that they're having moral distress could be simple things like GI distress, an upset stomach, or gradually having more acid type reflux kind of situations, headaches, body aches, tiredness. These all are symptoms that come from the compounded stress of moral distress. There can also be emotional shifts and changes. So the nurse might feel sad or angry. They could be quick-tempered and snap. They could be crying spontaneously for things that they don't normally cry about. And so it's an overreaction to the situation that's being driven by their moral distress. I think it's really important for nurses to not feel isolated and alone. These situations can make them feel that way, that everyone is against them and that if something is not going the way it should. So if they are trying to advocate for a patient and they don't feel heard or listened to, it's important to find those support systems within your unit or your organization. It could be something as simple as a chapter and going to an AACN chapter to look for help on how to navigate some of these issues. And so seeking support is key to trying to navigate these issues. And then I think the other thing is continuing to emphasize self-care, that we really take time to take care of ourselves. There are things that aren't within our control. and patients are allowed to make bad choices. So we may not always agree with the decisions of care that are made, but we need to know how to care for ourselves so we can come out the other side and not feel the burden of moral distress and not let it play havoc with ourselves and our emotional, psychological, and physical selves.
So the American Association of Critical Care Nurses, they're really leading most of the teams on decreasing moral distress. We notice there are higher levels of moral distress in the critical care areas and in the emergency departments. And so they have come up with an acronym on how to address issues that cause moral distress, and they're called the 4 A's. The first is to ask, affirm, assess, and to act. So the ask stands for review the definition and symptoms of moral distress, and ask yourself, what is it that you're feeling, and is it or does it constitute moral distress? Are your colleagues exhibiting signs of moral distress as well? And we could talk about COVID a whole other time, but COVID has really just added to the current level of moral distress that our nurses have faced before pre-pandemic. Affirm stands for affirm your feelings about the issue. What aspect of your moral integrity is being threatened? What role could or should you play? Assess is to begin to put facts together. What is the source of your moral distress? What do you think is the right action and why is it so? What's being done currently and why? And who are the players in the situation who are ready to act? And then act is create a plan for action and implement it. It's very similar to the nursing process. So what we are noticing is that 40% of our nurses at year 1 after graduation are leaving the field of nursing altogether because of high levels of moral distress. Specifically, what we notice here at Penn Medicine and other very large health systems is that in our curriculum in nursing school, we do not provide any education for our nurses about chronic pain, palliative care, care of the chronically ill, and then end-of-life care. So one thing we're doing at our college is that we're now integrating lots of different training into our program to help our nurses to be able to communicate with their families better, to be able to create more collaborative relationships with our providers as a healthcare team, so we know how to manage conflict and be able to escalate that through the appropriate chain of command, to be able to get the support that we need as staff, but more importantly, to take care of our patients the best way that they deserve. Other things that we're doing is we provide training to our nurses in compassionate listening. We have a special training team that comes in because they feel very strongly that every patient has a story to tell. And we're so busy as nurses, we rarely have time to sit down with them and talk to them and allow them to share their story. So we're teaching compassionate listening. We're doing a deep dive into the cultures and a lot of end-of-life care practices so our nurses have a full understanding of various cultures and how they can address it and support those families and the patients during those times of transition in your life. And we're also teaching our nurses conflict management to be able to address issues head-on and be able to advocate to the fullest extent of our practice as a nurse. So what are our new graduates saying? So there's a survey from Penn that showed Croxon, Derivan, and Anderson in 2018 found that new nurses do not feel prepared to care for patients in palliative and end-of-life care issues. Top areas of moral distress for our grads is having conversations and communicating effectively with patients and families experiencing end-of-life care issues. Also, a really hot topic not discussed here, but is inappropriate staffing issues, which has just been significantly worsened by COVID, which we could talk all day about, but that's another topic for another time that would be really interesting because we would love to know how it's being addressed in your culture as well. In a meta-analysis, unmet needs were identified in our new grads who had high levels of moral distress. Zhang, Lee, and Bloomer in 2016 identified 6 themes where graduates lacked training to cope with death and dying issues. Also, in a metasynthesis, 6 areas of deficiency. So these were the most common themes in the study: emotional experience or processing. So nurses really struggled in those areas. Facilitating a good death, support for the family, inadequacy of end-of-life care issues, personal and professional growth, and coping strategies. And these are all areas that we are addressing in our curriculum for our undergraduate students. And as I started mentioning some of the things that we're doing to empower our nurses, we're teaching communication strategies, we're working on compassionate listening training, which is a whole other great topic. We could talk for hours on that another time. We're working on role playing so nurses could actually work it out and try new communication strategies on each other before practicing on patients. And again, we can also use high fidelity simulation for this area as well. And then healthcare teams open to discuss all questions. And this is really important. This isn't just transparency among nurses. We know that these problems are multidisciplinary. We know that providers, physicians, and other types of physicians like doctors of osteopathy here in the United States are not trained in any of these areas either. So they're just as inept and unprepared to deal with these issues as our nurses are. And also support. And support meaning if a patient passes away or wherever the nurse is stressed within the process, we need to have a debrief and talk to the nurse and really understand how they're feeling and where we can play a role as more seasoned nurses or managers or educators in the role to make sure that our young nurses feel supported. From the literature, we know that there are lots of solutions that are working as we take theory into practice. So we're now creating multidisciplinary teams specifically trained in the areas of palliative care and end-of-life care. We know that if a regular provider orders pain medication, that oftentimes it's not sufficient for end-of-life comfort. So we know that multidisciplinary teams improve the patient experience significantly. We're also trying to focus more on culturally sensitive end-of-life care, having better communication with our families, like family meetings, just constant communication, because we're finding that we don't communicate often enough with our families to feel comfortable and supported throughout the process. And to start the process, we should always start with clear goals of care to understand what would be the ideal experience for this patient and this family in this situation. And then managing conflicts, because we know not only do we have conflicts within our healthcare team that we may not understand the issues or we're conflicted by the issues, but we also know there's a lot of conflict among families. And we see that happening even before the patient passes, where families are arguing about certain things, and it's inappropriate. It just should not be there at the bedside around the patient, and we need to help minimize and create the best experience we can for our patients. And then ethics committee. So I don't know if you utilize them, but we have an ethics committee in almost every hospital or acute care facility, and they are a great committee that we can go to describe ethical and moral issues occurring within our healthcare teams. And then again, if you have any questions in these areas, feel free to reach out and email. I would love to chat with you. And then these are the references used in this presentation. Again, want to thank you so much for your time and attention. It's such an honor to be talking to you today. I wish I were talking to you in person or synchronously so we could be much more interactive and friendly. But again, hope you have a great rest of your day. Thanks so much.